Hello everyone. In a former video about TMD diagnosis, we addressed the differential diagnosis of TMDs and started the diagnostic tools. We discussed how to take a good history from the patient and how to perform efficient clinical examination. Today we will proceed to the diagnostic aids. There are many additional diagnostic tests that help achieve the final diagnosis, but not an alternative for taking a good history from the patient and performing accurate clinical examination, like TMJ Imaging, electromyography, sonography, thermography, mandibular tracking devices, etc. In this video, we're going to focus about temporomandibular joint imaging, CT, MRI, panoramic views that are usually performed in the dental practice. In this video, we're gonna know how to select the radiographic modality relevant to the chief complaint and how to detect the abnormality and how to interpret the image. Now, when to order for panoramic view, MRI or CT. Panoramic view or orthopantogram usually asked for screening of gross abnormality in the TMDs, like odontogenic or non-odontogenic pathology, ankylosis or fracture, or any other pathosis. Before requesting MRI from the patient to assure the diagnosis, you should know what is MRI, when to request it, and what is the normal finding on the MRI and how to interpret it. If you are a beginner in image interpretation, you should know that osseous structures of TMJ like articular eminence, glenoid fossa, and condyle will appear radio opaque on the CT and the vice versa on magnetic resonance image due to the low water content in these bony structures, while vice versa the temporomandibular disc, which is the main cause to request an MRI, and the disc will not appear in the CT, but MRI density will appear in between the bony component and soft tissue component according to the water content. As you see in the MRI, the black layer covering the articular eminence and glenoid fossa and covering the condyle, it is the cortex which has the least water content, while the trabecular bone inside the condyle appear white due to high water content. And the articular disc, the biconcave one, will appear more green more than the trabecular bone. So now you conclude when to request the MRI. You request it when you want to visualize the disc if you suspect disc derangement disorder or disc displacement, and you will request CT if you suspect a bony disorder or advanced stage in osteoarthritis where the articular surface of condyle and articular eminence and fossa are eroded or crepitation is here by clinical examination. So when history from the patient or clinical examination suggests internal derangement or intracapsular disorder, we request magnetic resonance image and to visualize the disc, which can only be seen on MRI. What is the normal findings in TMJ? At the beginning, there are two views, sagittal and coronal views. In sagittal view, we order open and closed views. The open view, we check the disc shape and position, and in the open view we check the reduction of the disc in case of displacement. Is it reduced to recapture the condyle? And we also check the translation degree of the condyle along the articular eminence. Is it obstructed or normal pathway? The normal disc shape is biconcave with intermediate zone which is thinner than the anterior and posterior band, and the normal position of the posterior band is between 11:30 and 12:30 clock. Any displacement of the disc beyond this position anteriorly is considered displaced in the closed position, and if it's interpreted displaced, we should return to the open view and check if the disc recaptured the condyle during opening or not, to assure is it disc displacement with reduction or without reduction. The intermediate zone of the disc should also be in contact with the condyle and located between the anterosuperior surface of the condyle and the posterior inferior surface of the articular eminence. In the coronal view, the disc also should be centered between the condyle and the glenoid fossa without any displacement medially or laterally. We should also check the normal shape of the condyle without any condylar edema. Here is on the left side the normal disc position between 11:30 and 12:30, as we said before, and the normal biconcave shape with the intermediate zone, the bow tie shape or papillon-like shape. And it is the closed view, the disc is in normal position, and in the open position there is normal recapturing of the condyle and normal translation of condyle in the forward movement. Here in the open view, we check reduction of the disc and normal translation of condyle along the eminence. Here in the right side, the coronal view MRI, we can see the disc centered between the condyle and glenoid fossa with no medial or lateral displacement. So when reading MRI, you should review these items: the disc shape and position, the disc translation in an open view in relation to the articular eminence, disc displacement closed view, is it anterior displaced or in normal position within 11:30 to 12:30, the condyle edema, the joint effusion in both joint spaces or one joint space if there are loose calcified bodies within the synovial fluid. Here's the case of internal derangement. The upper one is disc displacement without reduction, where the closed view, the disc is displaced anterior beyond the 11:30 to 12:30 position, and in the open view we check it if it's placed to cover the condyle. If it's not so, it is non-reduced, so it is disc displacement without reduction. The lower view, a case of disc displacement with reduction, where we check first the closed view if the disc is displaced beyond the 11:30 and 12:30 degree, and return to the open view if the disc is recapturing the condyle to be reduced or not. Here is the disc is recapture the condyle, disc displacement with reduction. Here's an example of abnormality in disc position and shape. The left one, coronal view, the disc is displaced laterally, more laterally than the center, and the right one, the shape is disfigured. There is a deformity in the disc shape and you cannot identify the intermediate zone or the biconcave shape of the disc. Another example of disc deformity on the left side, the biconcave shape or intermediate zone cannot be identified, and on the right side, loose calcified bodies. By the way, it's a CT, not MRI, if you have noticed. Loose calcified bodies are detected in the joint space. On the right side, these bodies are calcified cartilage bodies embedded in the synovial fluid in a case called synovial chondromatosis. Here's a case of joint effusion. You should first localize the condyle, then the articular fossa and eminence. Between them, there will be a synovial fluid. In the upper compartment, this white shadow, this white color is the effusion or high water content due to inflammation or effusion in the upper joint space. And on the right side, the effusion occur in the upper and lower joint space. You can see the high water content reflected in this white color. At first, also, you should know the normal CT view. You should see the normal shape of the condyle surface, which is convex in shape with normally surrounded with radio opaque layer with no flattening or any erosion on the surface. This is the upper two views, while the lower one, erosion started in the condyle shape and the condyle started to be disfigured with on the right side subcortical sclerosis of the condyle. On the right view, flattening of condyle is well seen. So if you see the condyle with normal size and shape with no flattening or erosion or subcortical sclerosis, it is normal view with no osteoarthritis. If the case only is flattening of the condylar surface without subcortical sclerosis, or vice versa, like subcortical sclerosis without flattening and else normal, like normal shape of condyle, so it's intermediate for osteoarthritis. But if you see deformity of the condylar shape with significant erosion, so it is subjective for frank osteoarthritis. Here is also subcortical sclerosis, increased sclerosis of bone below the cortex and started deformation of the condyle. On the right side, a beginning of osteophyte formation is started. Here is osteophyte formation is well seen. This beak-like shape with subcortical sclerosis, and on the right side, gross deformity of the condyle is seen, and deformity also of the glenoid fossa with massive sclerosis of the articular surface. No trabecular bone is defined on the articular eminence or glenoid fossa. This is a frank case of osteoarthritis. Here are diagnosis tips that will help you achieve the final diagnosis. Number 1, clinically, when you take history from the patient, if you ask him to localize the pain, if the patient points with his finger to the TMJ rather than holding his cheek, so it's intracapsular disorder rather than a muscular disorder. Moreover, effective muscle palpation and functional manipulation will help you differentiate between the muscle disorder and intracapsular disorder. As we say before, effective circular motion with firm thrusts during palpation of the muscles is more beneficial than shallow thrusts that may not elicit any response from the patient and you may miss any trigger points in the muscle, which is characteristic for muscle disorder rather than intracapsular disorder. Moreover, to differentiate between the intracapsular and muscular disorder, functional manipulation should be well understood, as we say before. Restriction end feel in the form of soft end feel in case of muscle disorder, where the muscle threshold could be exceeded to increase the intracapsular distance while opening the mouth with 2 fingers, while intracapsular disorder like anterior obstacle by closed lock or disc displacement without reduction, attempt to increase the opening out distance will not be successful, and this is the hard end feel. Also, analgesic blocking of a provisional diagnosis, like if you suspect tooth or muscle that is the cause of pain, if you anesthetize this part and the pain disappears, this is here you made the diagnosis. Also, if trigger point injection elicit pain relief, then you reached the diagnosis. Regarding radiographic diagnostic tips, if you have different slices or images with different findings, like all slices interpreted as disc displacement without reduction or closed lock, and only one slice disc displacement with reduction, you should take the worst case scenario as closed lock and you should start treatment on this basis. In case of different slices interpreted as having disc deformity or perforated or highly deformed, but one and few slices only tells normal disc shape, you should take the best case scenario is the normal disc shape. As if you treated the case as deformed disc or perforated disc, that might proceed to increase disorder to advanced osteoarthritis. Here you may have proceed to the meniscectomy or disc displacement surgery, and this is not a conservative option. These two terms, osteoarthrosis and osteoarthritis, have been used interchangeably in literature, with osteoarthritis is the most common term and it involves pain as a main component, while osteoarthrosis is a degenerative disorder without pain component. So it's better to interpret the condition as a degenerative joint disease. Moreover, areas of radiolucency beyond the condylar cortex on CTs, interpreted as subcortical cysts, are misnomer. It's actually called osseous degeneration rather than subcortical cysts. Moreover, don't request OPG to interpret or diagnose early stage osteoarthritis, as osteophytes, for example, will not appear on panoramic view only if they are large or on the anterolateral surface of the condyle. And finally, loose calcified bodies on CTs in the synovial fluid is not a sign of osteoarthritis, but rather synovial chondromatosis or chondrocalcinosis. To sum up, we discussed temporomandibular classification to know the differential diagnosis, and diagnostic tools, history, clinical examination, which are the main parameters to reach the diagnosis, and diagnostic aids, mainly here the radiographic images, and image interpretation in OPG, orthopantogram, MRI, or CT. Also, we discussed diagnostic tips, clinical and radiographic tips. Thank you for watching. If you like this video or you get benefit from it, like and share with your friends.